Yes. So it's an honor to be here. Last year also I remember being here. And thank you, Corrado. Thank you, Franco. Thank you, Antonio. It's so good to see you guys back again and all the crowd here. It's an amazing feeling because I was in Parma in 2015, I guess. After the Rome meeting, I was in Parma. I loved the cheese. I still look for it everywhere. Wherever I go, I look for Parmesan cheese. But I think I have to come there to get it. So we start this talk right now. I always start the last major surgical advancement in trauma is decompressive hemicraniectomy, which was devised more than 100 years by Cocker. Now, let me show you some scans straight off. That is a scan of a child. Please have a look at it. The patient presented with a GCS of M5, but later on deteriorated to M2. So you can see the cisterns were all very clear initially. So we didn't want to operate this child. You can see there's a fracture there. So we didn't want to do anything. We just wanted to conservatively admit and manage conservatively. But this child deteriorated to M2. We had to take him up, and you can see the post-op, immediate post-op scan. You can see how much damage is there. You can see this catheter there. And the one thing I would ask you to notice is that even with this considerable damage, you can see that the bone flap could be kept easily back. Now, I mean, many of you might agree with me that in a usual setup here, we would have gone for a bifrontal decompressive. You would see the results here. This is the scan at discharge. This is when he was going at discharge, and this is him after at his follow-up. Now let us see. These are the 4 observations that I always tell people. One is trauma and acute SAH look similar. Now it is completely different, 2 different things. Acute SAH, the subarachnoid hemorrhage is more localized. It is very high pressure. In trauma, the subarachnoid hemorrhage is more diffuse and it is low pressure because it is capillary bleeding. But opening cisterns for subarachnoid hemorrhage gets the brain to be lax. Opening the cisterns in other pathologies also gets the brain to be lax. And in trauma, I'm sure if there are any old hands there, very senior surgeons, they would tell you that in Europe, in Asia, people used to do temporal lobectomies. People used to cut the tent to reach the cisterns, and it was practiced for a long time, and it had excellent results. I know. So a lot of old surgeons, very senior surgeons, have told me that they used to do this before. These are the papers which shows those kind of findings. So. Now, one thing I always see when I go to a lot of presentations, I see that first the ICU guys manage the patients for a long time, and when the patient ICP is uncontrollable, they go ahead and do the craniectomy. Let me tell you, this paper is interesting because if you have to do a craniectomy, you have to do it early. So the same way, cisternostomy, we do not wait for the ICU guys to cook it up and then give it to us for cisternostomy. Then it would not work for sure. So we do a proactive surgery. Now I know there are many there are many ICU specialists out there who will not agree with me, but you must understand that the other choice that you have, decompressive craniectomy, as my good friend Jamie Cooper has proven, that it's not much of a use actually. So this is our comparison when we were doing DHC. This is not simultaneous. This is over a period of time, which was our DHC, our series of DHC. Then when we started to open cisterns, especially the anterior cisterns, opticocarotid and the interoptic cisterns, we were not opening membrane of Lilliquist. So at this point of time, we were doing cisternostomy, but we were doing DHC along with cisternostomy. Now that is what everybody has started doing. A lot of people in India, a lot of people in Africa, a lot of people in China has started to combine DHC with opening of cisterns. That's what, at that point of time, this was our mortality. Then when we started to do cisternostomy alone with not such a large flap, but reasonably large flap. But after that, we started having our selection criteria. I will discuss that selection criteria later. Now, after that, this is our mortality. This is our ventilator days. These are our ICU stays, and this is the mean. So, now, so this is our indications after 4 years. So, severe head injury in adults with significant brain swelling, cisterns not visualized. Acute subdural hematomas with mass effect, even if they don't classify as severe head injuries with respect to GCS. So some people might ask me, why do you go ahead and operate on patients who's got a GCS of 13/15? Obviously, if they have mass effect, if acute subdurals have mass effect, there's a good chance if the mass effect is significant, even if the GCS is 13/15, sometimes you have to operate. And in that case, many people tell me, why can't you take out the subdural and come out? Yes, you take out the subdural and come out, 1 out of 9 cases will deteriorate again. So if you open the cisterns, the chances of deterioration, and it takes only 20 minutes extra to open a surgeon like Antonio Romano, who has done this, he will tell you to open the cisterns. Once somebody is doing aneurysm surgery, you want to open the cisterns along with your acute subdural evacuation. It takes hardly 10 to 15 minutes. So for a resident, it will take maybe 20 minutes. Multiple unilateral and bilateral contusions in combination with STH and mass effect. Pediatric brain injuries with severe brain swelling. Traumatic subarachnoid hemorrhage with swelling. So, what are the advantages and disadvantages of cisternostomy? In a nutshell, we can keep the bone flap, so there is no second surgery. The mortality, morbidity, ventilator stay, and hospital stay is reduced compared to decompressive craniectomy. They do develop pseudomeningocele. 35% of them, they do develop pseudomeningocele. May have the same incidence of blooming of contusions. I saw a very good talk by somebody about the disadvantages of decompressive craniectomy. Excellent talk, very good talk. So the same incidence of blooming of contusions are seen in cisternostomy also. But this does not really reflect on the ultimate prognosis. I will show you some cases actually. Infection rate is similar to that of DHC if drain is inserted, much lesser with no drain. But now we have started inserting drain for almost all cases. This was my initial finding. I would now we are very careful when we insert the drain. So how does this work? In severe head injury, one of the things that I always ask the audience is, where does the CSF, there's 120 ml of CSF, where does it get displaced to? And immediate brain swelling. So in 2 hours, if you notice, somebody had put up a time profile, but we see that in our emergency setting, we see that 2 hours after the patient gets a severe head trauma, there is severe brain swelling and no cisterns are seen. So where does this, in 2 hours, where can the CSF go into? And why is this immediate brain swelling? There are a few things to consider. One is the volume of CSF in ventricles is 25, volume of CSF is 120, volume of spinal subarachnoid CSF is about 40 to 70 ml. So, in Maryland in the 1980s, Grady and colleagues postulated that there is existence of solute exchange between the interstitial fluid, ISF of the brain, parenchyma, and the CSF via the paravascular spaces. So, CSF is going into the brain. Now, who proved this? The landmark paper of Iliffe and Nedegard, they proved this. They proved this in 2012. From 2007, I have been trying to tell that CSF is going into brain. I mean, in Nepal, you could understand that we don't have any facilities for huge basic research or anything. We were sure that the CSF is going into the brain, but we didn't know how. But after Iliffe and Nedegard's paper came into being, this was much more easier for me to prove. So you can look at it. This is the Monroe-Kelly doctrine. Brain expands, CSF and blood has to reduce. Okay. Now let us look at the principles of cisternostomy. So, cisterns, there is subarachnoid hemorrhage. In every single trauma, there is subarachnoid hemorrhage. When subarachnoid hemorrhage happens, I told you, in trauma, it's a diffuse subarachnoid hemorrhage. When there is a diffuse subarachnoid hemorrhage in the cisterns, the pressure goes up to mean of about 50, and then the cisternal pressure starts rising. And when the cisternal pressure starts rising, the blood cannot go into the brain because the Virchow-Robin spaces are too small for that. So what goes into the brain through the Virchow-Robin spaces? The CSF goes to the brain. When the CSF goes into the brain, this is what happens. The cisterns disappear and the brain starts swelling. This is very important. We call this CSF shift edema. And this has been published to SNI, World Neurosurgery. Everywhere now, it is a term which is getting accepted slowly. We call it CSF shift edema. It is not cytotoxic edema. It is not hydrostatic edema. It is CSF shift edema. Now, we drain the cisterns. This is what happens. This is physiological. Now, on the other hand, you go and open an edematous brain. The CSF has gone into the brain. You go and open that brain and do a decompressive hemicraniectomy. You are decreasing the ICP for sure, but you are allowing a swollen brain to shift out of its natural box. The stretch injury to axons is severe, and that is what causes the severe atrophy. All of us have seen that. The severe atrophy after the decompressive hemicraniectomy is done. You see that. So, a lot of people ask me, how does the pressure go up in the cisterns? Multiple subarachnoid hemorrhages, the contusions. Subarachnoid hemorrhages is what produces the intracisternal pressure to go up. And this is what causes the CSF shift in the brain through the Virchow-Robin spaces. So, this is a picture that I saw. It's very interesting. There are doors for CSF into the brain. Now, these are the type 1 VR spaces. These are the type 2 and 3 Virchow-Robin spaces. And this is what is happening in CSF shift edema. It is published. It's published widely. I would give you the publications also. So, after this has happened, you open the brain, which is a tense brain, and you open the brain. This is what happens. You've seen that. Everybody's seen that. We do not open that. We drain this part, and that is the CSF shifts back. Now, is there a direct correlation between open cisterns and mortality? Yes. So there is a paper, Totant in 1984. There's a paper that 77%, 39 and 22 described an absent, compressed, and normal system. So this is one of the very important findings in a scan. So if you have an absent cistern, if neurosurgeons knew hydraulics or fluid physics, you will understand that it is impossible to compress fluid. So you take 100 ml of plastic bag and try to compress it to nothing. It's impossible. A lot of people, when I asked them, where did the CSF go? They said, oh, it's fluid. It got compressed by the brain. Not brain. Even steel cannot compress this 100 ml of fluid into nothing. It's impossible. So the hydraulics, the whole physics of hydraulics works on that. So it is impossible to compress it. So the fluid has to go somewhere. So when you have a swollen brain and you have absent cisterns, you should know that the fluid went into the brain. Now there are some corroborative evidences. Now this is the article which shows that the CSF goes into the brain. So they injected intracisternally and ventricular. They injected markers. This is the ventricular markers on this side. And this is the cisternal injection markers. You see, if you inject into the ventricle, nothing gets into the parenchyma. Nothing. Almost nothing. While you inject into the cisterns, everything gets into the parenchyma. This means that the ventricle is in the production cycle. The ventricle's job is to produce the CISTERN. From the cisterns, is when the communication cycle, that is when the CISTERN goes in. And it is very interesting. Now we were wondering why the CISTERN goes in. It is for cooling and cleaning. There is another paper called Cooling and Cleaning, which you published. That may be very interesting for you. There's one more paper called Exploring Virtual Spaces, also published in SNI. So this is their conclusion. Subarachnoid CSF rapidly enters the brain parenchyma. This is the same principle physiology for cisternostomy. So the gateway that does it is aquaporin 4. So this is the increased expression of aquaporin 4 in human traumatic brain injury. It's corroborative. When is a cisternostomy not useful? Now, we had a few cases where cisternostomy, so when you have a motor score of 1 and 2, some cases might improve combined with radiological features of ischemia, but now we have brought out a Nepal Calgary clinical radiological score, which is much more extensive than this. If we have time, we will discuss this also. Let's see some scans. Now, are the scans being seen? Corrado, can you see the scans?
Yes. We see it's a little bit little. If you can enlarge the picture, it could be better. Otherwise, go ahead.
No, one second. What do you think about, can you see the scan?
Yeah. Yeah.
This is one of our very early cisternostomies. Okay, where we used to do it with the, we were not able to put the, you can see the bone flap, this part, we have kept it. Somebody put this as a confused decompressive hemicraniectomy. Yes, it is a confused decompressive hemicraniectomy. But, you know, this is one of the cases which proved us, this is a case where this disease was 4/15. This will probably done in 2012 or something. So, you see the cisterns are open here nicely.
It should be IPE.
Beg your pardon?
Yeah, IPE. You can get rid of that banner at the bottom if you click on hide.
Ah, thank you.
You click on the hide there. There you go. Okay. Thank you.
So now this is the video for that guy.
क्या नाम है तुम्हारा? नाम क्या है?
Same guy. So this is a chapter in the WFNS textbook. This is cisternostomy from one of the authors is an Italian. He had come to us. See, cooling and cleaning the brain, this role of CSF and paravascular system, paper, CSF shift edema. This is an article published from Iran, one of the largest universities in Iran. They have done a cisternostomy, and it's a cisternostomy published in the World Neurosurgery surgical technique. This is published in AJNS, I think. This is an SNI, Exploring the Virtual Robin Spaces Function, Unified Theory of Brain Diseases, Anatomy and Physiology of Cisternostomy. Again, two Italians here, one based in Palermo and the other based in New York. Yes. Now, I would like to go through a few scans. Yes, I'm sure many of you would agree that we would do a decompressive hemicraniectomy here. Look at this. You know, one of the important findings in here is that this cistern is widened. Whenever this cistern is widened, this means that there is impending herniation. This is very important for us because when we see this sign, we do not wait. We take the patient up for cisternostomy, because if this sign is there, that means the temporal lobe is, the uncus is pressing on the midbrain, and when the midbrain is displaced, the pons also gets displaced, and this cistern gets widened. So this is very bad. This means impending herniation. This patient already had his left pupil dilated. This after cisternostomy, came walking 10 days later. You can see that even the contusions we didn't take out. Okay. This contusions we didn't take out, this contusion we didn't take out. There is an extradural, but the mass effect is much less. Okay. This is another one, traumatic subarachnoid hemorrhage. Okay. This is 14/15 deteriorated to 4/15, the right pupil dilatation in 12 hours. That is after cisternostomy. This was 14/15 at discharge, the residual third nerve palsy, improved in 6 weeks, 15/15 in 6 weeks. This is the child's. So there is a lot of, I mean, if you would go on to my Facebook or we post all the cases of cisternostomy now, there is Dr. Roy Thomas Daniel in Lausanne, who started his prospective trial for the first time in Europe now. So Lausanne is doing cisternostomies. Lausanne is doing cisternostomies with decompressive. Sometimes now after opening membrane of Lilliquist, they are able to put the bone flap back. So they've started their first prospective trial in Europe. And 2 more prospective trials, 1 major trial in India and 1 major trial in China is going on. So the major trial in India is being done by Dr. JKBC Parthaban. He's already presented his series of 30 patients with cisternostomy in the last Neurosurgery NSI conference. And things are going forward. So I remember Antonio telling me that what is politically correct, that is what he would be saying. I understand. But, you know, we must understand one thing. Unlike in Europe, in our continent, in our place, in neurosurgery, the major killer is trauma. I put all my aneurysms. We are a center which does almost 150 aneurysms every year, but we do almost 600 traumas every year. So in a center like ours, if we do not care, look at trauma in a microsurgical way, I mean, you know, people have evolved. Just meningiomas, earlier there were people who used to take out meningiomas with a finger. Aneurysms, people used to operate without microscopes. All that surgeries are gone, only for trauma, because trauma comes in the night. Big neurosurgeons are not available in the night. You have to face it. There is no question. If anybody says that, no, I don't operate trauma, it is because it is a shame. It is not that it is a big achievement. It is a shame that big neurosurgeons do not go for trauma. It is a residence, and that is why trauma being the biggest killer in neurosurgery, still now trauma has not received its due share. Nobody uses microsurgery in trauma. It is one of the most difficult cases, yet nobody uses microsurgery in trauma. So we have to change this thing. We are a group of experts sitting here, and we have to change this. We have to look and ask ourselves that whether we should sit down with this primitive surgery, decompressive hemicraniectomy, which was practiced 100 years back, no sophistication, nothing, and we still want to go ahead with it, or you want to change? I mean, you may argue that this is an overkill, going for membrane of Lilliquist opening and all that. But don't you go for the same thing in a basilar tip aneurysm? If somebody told you basilar tip aneurysm, just, there is subarachnoid bleed, just open, do a decompressive hemicraniectomy and come out, will you accept? So why do you accept in trauma? So we have scientific principles now. We know what is CSF shift edema now. Please, I would like you, all of you, to go through these papers, see whether it is practical. Decompressive hemicraniectomy was the only workhorse of trauma neurosurgery so far. Time to hand over the baton. Thank you.
Okay. Thank you, White. Just some consideration. before to attend some question from audience.
I will stop.
Before to decide, yes, before to decide if the compressor or not, usually we study the patient, so we do not decide that the compressive just on CT scan. So this is the first consideration. The other good consideration that after just 1 year, we get close our position, because yesterday, the last year, we have not cisternostomy in our video for decompressive technique. And now this year, we show the cisternostomy as a possibility, as a chance in the compressive technique. And you, last year, did not show who doesn't benefit from cisternostomy. And this year, I read on your slides that there is a population patient where the cisternostomy doesn't work because these people has a cytotoxic edema, and as you explain in the cytotoxic edema, the cisternostomy doesn't work. So for me, it's not the time to pass the bar, but it's still the time to talk about this passage. And maybe in the future, I'm sure that we individuate which patient needs cisternostomy and which patient needs decompressive craniectomy. And I think that we are working together in a good way. We, as I told you a lot of time, we are waiting for your population. So now you announce these two studies, so we wait for this study to understand better. But you know how we are agree with this technique, with this possible solution, but we have to understand the right indication. So if you have some question from audience, please take that. Cherian waiting for us. He take a dinner. Now he's bedtime. So I want to thank very much Hype, and for this reason, it would be useful that you make some question to honor this presence.
Maybe.
Thank
you very much for your time. I want to ask.
Can you hear him?
Can you hear me?
Yeah, I can barely hear him.
Come to the front. Come to the front.
Okay. Can you hear me?
Yes. Yeah.
Okay.
Yes.
I just want to know: is it always possible to reach the cisterns when you're to do the cisternostomy, or you may find the brain with the too much edema, too much swell to reach them? Thank you.
Yeah, I mean, it is the most common question that I have been asked in the last 10 years. I mean, whenever I present this case, whenever I present this surgical technique, people ask me, the first question that they ask me, how do you reach the base? So my answer to you is, I would use a skull-based technique. So you are drilling a lot of planum, you are drilling the sphenoid ridge off. Sometimes you do partial clinoidectomy, and sometimes you use you drill off the base and then you reach as close as to the suprasellar cistern. Now there are videos in YouTube showing how I reached here, but in spite of all this, sometimes when you open in the base, you have liquid brain coming out. These videos are also there in my Facebook. If you go into my Facebook and see the videos, you will see that when you open, sometimes just liquid brain just comes out. Okay, these are the worst cases. You don't see this very often, but sometimes just liquid brain comes out. But in spite of that, once you reach the cisterns, Once you reach and the interoptic nerve, that is optic nerve is your landmark. This will not change anyway. Optic nerve, and you go between the optic and the carotid, and then you start training CSF, things get better and better. And then if you are confident enough, and then if you can open the membrane of Reliquus, it becomes even better. And then you keep on irrigating out all the blood, the brain becomes quite lax and manageable. There are many, many videos. If you go to Raju Cherian, if you go to YouTube and see Raju Cherian, you will see the videos, and you can see the technique.
Okay. Thank you very much.
Okay, once more question.
Well,
Please go on.
I'm sure a lot of people will have questions, but they will keep it in their minds to be very polite, probably.
How are you, guys? Hi, this is Stefan. Remember we talked at the World Federation. It's okay. Can you hear me?
Hello.
Hello.
I think tell me. I can hear you now.
We've been publishing for many years together with Tony Marmaro from Medical College of Virginia, and kind of find out that the predominance of brain swelling, post-traumatic brain swelling, was cytotoxic. Plus, at the very beginning of the trauma, there is still a very vasogenic or interstitial, whatever you want to call it, cisternal CSF or cisternal water. One thing is for sure, and this is an MRI data, the water is full of brain. The brain is full of water. And the question was where the water comes from. So everybody were convinced that the water should have come from the vascular space, from the plasma, from the blood. What you said about the transmantile gradient of CSF from the ventrix to the cisternal compartment is being demonstrated, but in a very small quantity. There is not much of CSF going from the ventrix up into the cisternal. Now, this is the first time I hear that from the cisternal goes into the brain, soaking the brain to the ritual lobby, which is okay. I can still do that. But the problem is that most of the CSF leaves the system and goes into the real buffer of the system, which is the cisternomania in the spine. Most of the CSF will leave the cranial compartment and dislodge into another compartment. I agree with you that they are incompressible. Fluids are incompressible. Now, what we don't understand is there is half of trauma literature focused on mitochondrial damage, energetic damage, cellular swelling, diffuse axonal injury. This is probably, I will start doing it. That's a promise. I will give you 10 cases by the end of the year. Okay, and let's see what's going on. But the rationale of this physiopathological explanation is still, for me, not very well understood. Because we need to discard half of the literature of the last 30 years. We need to find a way to merge this data together. Otherwise, if the prognosis of TBI is only linked, the CSF disturbance, we will go and treat this hydrocephalus, pseudotumor, brain swelling, everything with the cisternostomy, if the problem is the CSF. The CSF is considered the buffer of the intracranial hypertension. So I really am excited. This is the second year now that I'm confronted to you. I would start doing it because this is a cornerstone of every vascular surgery, is to go there and open the system. But we need to speculate of something else, rather than this simple mechanicistic vision of the CSF getting into the brain, and then we reopen the system, and then we come out. I think this is too mechanistic. We need to understand a little better.
Any reply?
No, thank you for the comments. Now, can you hear me?
Yes.
Yeah, a few things I wanted to put up. See, when we started cisternostomy, we didn't understand anything about the physiology. You know, it was an accident that we started it. I must confess to you, it was because I mistook an aneurysm case for a trauma case. That was how we started it. So it is something called, it is serendipity, which means one of my residents in 2006, I was a consultant. That was almost 11 years back. When I was a consultant in my hometown, there was two cases. One was a trauma and one was an aneurysm. So as usual, I had finished my skull base and vascular. I wanted to do all the WFNS grade 5 aneurysms. So I told the resident to post the aneurysm first and then the trauma. And when I went there, this guy had opened a large flap. The brain was looking very angry. And I opened the cistern, the opticocarotid cistern. And after that, I started looking for the ACOM and I couldn't find the ACOM. And the brain was lax, but I couldn't find the ACOM. So I asked the resident, what happened? Why is this? There is no aneurysm. Whatever you showed in the angio, it is not correct. There is no aneurysm. He said, no, this is the trauma. So I got very angry with him. I wanted to strangle him. I asked him, why? You posted this case. I told you to first post the aneurysm first and then do your trauma. Why you posted this first? So he said, the patient dilated a pupil and that is why I posted the case first. Then I said, when I came, why did you not tell me that this is trauma? So he was watching me, having all the fun. So that I was looking for the aneurysm. But when I went back in the night, I thought, if we did a decompressive hemicraniectomy for sure, but I thought I could keep the bone flap back because the brain was so lax after this. So this is the origin of my idea. So this is why I started doing this. And then we started opening cisterns for all the head injuries along with decompressive hemicraniectomies. For almost 300 cases, we did decompressive and started opening. And at that time, I was not competent enough to open the membrane of Lilliquist in a very tight brain. And therefore, I could not open. And therefore, I had to go back to Japan and train with Sano again, that in very tight brains, how do I open membrane of Lilliquist? So we started learning about PCP drilling. I went back to the lab, drilled PCP in cases which is needed. And then we started opening membrane of Lilliquist, and then our results further improved. It is not a gradual thing. I'm sure a lot of you might have heard me for over 10 years I have been presenting this. So, yes, the evidence is still sketchy. The evidence is not still proven. I agree to this. But I am pressing on with this, and I am seeing a lot of success because a lot of surgeons have started doing it. And the best evidence is to see for yourself. If you open the cistern and you see the brain getting lax, because I have many surgeons now who tell me, now today one surgeon has sent me some beautiful videos. He's probably doing it better than I do. So once they see the joy of it, once you have seen a lot of decompressive hemicraniectomy, it is a primitive surgery. If you are doing it, you must understand. Somebody who is as good as Antonio Romano, I'm sure he doesn't like this decompressive hemicraniectomy a lot. I'm sure any of you surgeons will not like it a lot. So my only point is, I understand, I agree that I do not understand, or I do not know the entire physiology, but this is common sense. Do it and then see it, and then we can together discover what is the physiology.
You're right. Everybody of us who studies CSF circulation knows the rules of basal cistern in the circulation. It's basic on CT Rotterdam score, the basal cistern. We publish the basal cistern, how is a prognostic factor on the evolution of the contusion. More than 10 years ago, we in some study that I published with monitoring of ICP after third ventriculostomy, endoscopic third ventriculostomy. There was an adaptation period after the ETV, and this adaptation period, the patient take time to restore normal ICP values. The people who have basal cisterns effaced from the pathology, like abstinence aqueduct stenosis, came in normal value more rapidly than people where the basal cistern were affected by pathology. So the basal cistern is basilar, is a basic pathway for the normal function of CSF circulation. What we are searching for is the explanation. What we are searching for is if it's right, in which patient we have to risk to come up inside the basal cistern, in which patient we have to use the microscope to take away the clinot, and which patient it's enough just dural decompressive. So we cannot be just soldier and to obey a command, do this. We have just to understand why to do this. And I think that we are together try to better understand the pathophysiology. I think that we have an agree with the searching of the throat. If there is some other question from the audience.
Audience. Thank you so much, by the way. Thank you so much.
Thank you very much. It's an honor.
Okay, so the people want to come back to the lab, and they are very grateful to you for this discussion. And I can say to John that we can stop the recording. Okay, thank you so much.
Thank you very much.
Okay.